Everyone, and welcome to this week's COVID-19 office hours. We're going to just take a brief moment to go over a couple tech notes and then get right into today's great content. So just as a reminder, we are recording today's webinar, and we will post a copy of both that recording along with the slide decks and any content from the chat to the HUD Exchange. It'll be up there in just about 2 to 3 business days, and you can find it on the link that's up there on your screen. If you have any trouble with the audio during our webinar today, we encourage you to switch over from your computer audio to your phone, and you can do so by dialing in on the numbers that are both up there on the screen and that are in the chat box for you right now. Everyone that is an attendee today is going to remain muted for the duration of the office hours, but we absolutely want to hear from you throughout and encourage you to do so by sending in any questions, messages, feedback, thoughts that you have in WebEx through the chat feature. You can find the chat feature by looking down at the bottom of the right-hand side of your screen. You will see a message bubble and the words chat. Just click on that and it'll open it up for you. When you send in those messages, and again, send questions in that way as well, please, just take a moment to please make sure that the to is set to everyone. That helps make sure that all the attendees and the panelists get those messages. It should default to 2 for you, but if it does not, just click on the arrow and scroll down. With that, I'm going to turn things over to Norm Suchar from HUD's Office of Special Needs Assistance Programs. Norm?
Thank you so much, Natalie, and welcome everyone today to the office hours session. I want to quickly introduce our guest speakers and jump right into the content. We have great stuff today. We expect the session to go 60 minutes, maybe a little longer today. So we're going to hear from, as you can see on the screen here, you'll hear from some of our SNAP staff, myself, Norm Suchar. You'll also hear from Brett Esters, Marlisa Grogan, and Sharon Singer today. You'll hear from one of our great TA providers, Heidi Schulp. And we are very pleased to have Nelson Gonzalez from the Texas Healthcare for the Homeless program with the presentation today. So we're super excited to have Nelson join us here. We'll also have our regular update from Ashley Meehan from the Centers for Disease Control and Prevention. So we have a great set of materials and things we want to talk about today. Also want to let everyone know we do have a poll question about how the pandemic has changed how you are working with your healthcare for the homeless programs, or if you're a healthcare for the homeless program, how you're working with the continuum of care programs. So Micah just put the link to that poll in the chat window, so please click on that and fill it out and let us know how that has gone. So with that, I'm going to turn things over to Ashley to give us our CDC update. Ashley?
Hi, everyone. It's so good to be with you. My name is Ashley Meehan, and I am a health scientist on CDC's homelessness unit within our COVID-19 response. Next slide, please. So this is what our level of community transmission currently looks like across the country. And so this shows the level of transmission by county, with red being high levels of transmission. And so as you can see, we're still pretty heavily in the red zone, but the number of counties that are in the red zone is going down. So if we look at that little box on the right-hand side of the screen, we see that a smaller percentage of counties are now in the high transmission zone. So I think we're moving in the right direction, which leads me to my next slide, please, Micah. So this forecast shows us where we think we're headed over the next 4 weeks in terms of COVID-19 cases. And so as you can see, it looks like we are headed in a good direction downward, with fewer cases hopefully happening over the next 4 weeks. So again, this is a good sign. This is the direction we want things to be heading. But again, want to make sure that we highlight the need for layered prevention strategies, including vaccination. Next slide, please. So this is a little bit of a new visual. We haven't done this one before on office hours, but I think it highlights a few things that we kind of know, but it really helps visualize them. So the first thing I want to point out is that this shows a number of different charts looking at the average, 7-day average of new cases per 100,000 people. Also shows the percent of people fully vaccinated against COVID-19, and then over time, so from January of 2021 to now. And then it also breaks it down by age. So there's a lot of different things happening here. But each graph represents a different age group. So you can see on the top left, those are folks younger than 12 years old. The blue shaded area, which represents the percent of people fully vaccinated, you can see there's nothing for those under the age of 12 because vaccines have not yet been authorized. So that's kind of what we're looking at. I do want to draw your attention to when this curve of percent fully vaccinated starts rising. So if you look at the bottom right, those are folks who are 75 and older. So we can see that those, the percent of people fully vaccinated really started increasing in late February and early March, and that makes sense because in the phased approach, they were one of the first ones able to receive the vaccine. And then if you look at the bottom left one, we see those who were 50 to 64 came a little bit later, around April, and then again we see, you know, those shifting as groups became more available. Next slide, please, Micah. I also want to point out, as we see the percent of people fully vaccinated increasing, we also still see some peaks with cases as well in the last month or two, and that's due to the Delta variant. So we can see that the number of cases is not as large as it was back in January and December, but we still saw an increase in cases because of Delta. So that, again, just highlights the different transmissibility of Delta. And I want to point out that the peak of the Delta cases for those 75 and older, so looking at the bottom right graph, that peak is a lot smaller than the peak for those who are 18 to 24, who are 16 to 17. We saw a much higher burden of Delta among those who are younger. And that could be because they don't have as many people vaccinated. And it also could be for a number of other different things and risk factors, like being back on a college campus or you know, not wearing masks around their friends anymore, any number of things. But I hope that wasn't too confusing. I know there's a lot of different moving pieces in this visualization, but I think it just highlights, you know, who's vaccinated, how vaccinations are helping keep cases down, and why that's important. Next slide, please. I also want to highlight an MMWR that came out this week, highlighting an outbreak that occurred in a federal prison. So in this study, there were a lot of people in a federal prison who were fully vaccinated, but then there was still a large outbreak. So even those who were fully vaccinated did have what we consider breakthrough infection. So they did test positive for COVID-19 with the Delta variant. This MMWR is really important because it highlights that in settings where physical distancing is difficult or limited, like a prison or like other congregate settings as well, there's really a need to make sure that in addition to vaccination, we're still masking, we're still keeping surfaces clean, we're still trying to cohort folks and keep those who are symptomatic away from other folks. So those who were not vaccinated in this study were more likely to be hospitalized. There was one death in this outbreak among someone who was not vaccinated. So even though people who were fully vaccinated still got, or still had the possibility for contracting COVID and having a breakthrough infection, their outcomes were not nearly as severe as those who were unvaccinated. So again, still really want to prioritize vaccinations for everyone who is able, and in addition to that, continue those layered prevention strategies. Next slide, please. There is one more thing I want to mention. I know we've heard a little bit of buzz about this just before I end. Yesterday, I am totally just blanking on what ACIP stands for. Oh, Advisory Committee on Immunization Practices. The ACIP met yesterday. It's a Friday afternoon, please bear with me. They met yesterday to discuss boosters, and CDC has endorsed their recommendations for boosters for Pfizer vaccines only at this time. So this doesn't apply to folks who received Moderna, and this does not apply to folks who received the Janssen or Johnson & Johnson vaccine. But we have expanded those who have received Pfizer who are recommended to receive a booster. And I'll put a link to the press release in the chat, but just want to mention that that did happen, and we will have some guidance forthcoming on that. So with that, I will pass it back to you, Norm.
Thank you so much, Ashley. And here's hoping that the trend lines continue in a positive direction. But thank you so much for providing that update. So moving to the next slide, I want to just talk about a resource that's available for some of you might be interested in. This is an FAQ document produced by the National Healthcare for the Homeless Council. We'll put the link in the chat window, so if you're interested and this applies to you, that you can easily access it. But this really gets to tries to address the question of, if you work at a healthcare for the homeless facility, how do the vaccine mandates apply to you? So if that sort of describes you or nearly describes you, we strongly urge you to take a look at this this FAQ and read through it and see how it applies to you. And we want to thank our partners at the National Healthcare for the Homeless Council for putting this together. Next, we're very excited to go into one of our featured community presentations. I'm delighted to introduce Nelson Gonzalez from the Texas Healthcare for the Homeless program. Nelson, I think I'm just going to turn things over to you.
Thank you, Norm. Good afternoon, everyone. First, my name is Nelson. I'm a grants project manager for the Healthcare for the Homeless program of Harris Health System, which is in Harris County, Texas. I would like to thank Dr. Barbara DiPietro for connecting me with HUD to discuss the implementation of telehealth services and funding used within a Healthcare for the Homeless program. Next slide, please. First, I will describe our program and then get into the section on telehealth evolution. Harris Health System is part of the Harris County Hospital District. It is the nation's fourth largest public healthcare system, and it encompasses 2 acute care hospitals, Ben Taub and LBJ hospitals. We have 18 community health centers, 5 same-day clinics, 5 school-based clinics. We also have dental, radiation, rehabilitory, and dialysis services. Harris Health has the nation's first freestanding HIV treatment center, which is Thomas Street Health Center, and a lot of research has come out of that institution. And Harris Health has the first HCHP in Houston, which is the Healthcare for the Homeless program, which was established in 1987 and first funded by HRSA in 1988. And we currently have 7 clinic sites. Next slide, please. This is a map of Harris County, and the city of Houston is located within the majority of the county, and then in a couple of adjacent counties, including Fort Bend County. A majority of our clinics are located within the downtown area, as that is the area where a majority of the people experiencing homelessness in Houston live, and where a majority of homeless services providers are located. But we have a couple of clinics outside of the downtown area. Next slide, please. The services that we provide, we started providing primary healthcare services in 1988. We also have mental health services, including psychiatry services, behavioral therapists, and case managers. We have a contract to provide inpatient substance abuse services. We have dental services that we provide on a mobile unit. We also have health promotion and prevention services, case management with social workers, an RN case manager, and 2 behavioral therapists. We also have an eligibility assistance program, and all of our clinics have a Class B pharmacy. And just last year, we started our telehealth services. Next slide, please. We have 7 homeless programs in Harmony House, Lord of the Streets, Open Door Mission, Salvation Army Adult Rehabilitation Center, Salvation Army Family Residence, the Star of Hope Cornerstone Community, and the Star of Hope Men's Shelters. And if you see the first 3 have an asterisk next to them, and that is because those are open access shelter facilities. So those facilities allow our clinic to see patients that are residing in that facility or from outside, including on-shelter homeless. The other facilities only allow us to see residents of that facility for security reasons. Next slide, please. We have a robust mobile health program. We currently have 1 medical mobile unit, 1 dental mobile unit, and 1 outreach immunizations van. And we recently received an American Rescue Plan Act funds. And with that, we will be adding a medical unit and a unit with multiple services on it, including for immunization, laboratory services, and HIV care. And then we will be adding a new service for vision care. We currently have outreach to over 30 sites, including numerous shelters, campsites, soup kitchens, and other areas where persons experiencing homeless congregate. Next slide, please. This is a picture of our current mobile dental unit. And we provide services to both adults and pediatric dental care. Next slide. And this is our mobile medical van. And like I said earlier, we'll be adding another medical mobile van soon. Next slide, please. This is some data based on the last UDS report from 2020. Last year, we saw 8,335 unique individuals that were experiencing homelessness. We had 25,080 clinic visits, and 20% of those were through telehealth services. And again, we started providing services via telehealth for the first time last year. 79% of our patients were uninsured, 70% male, 30% female, 6% were ages 17 or less, 17% were ages 60 and over. The vast majority of our patients are of African American race, 35% were white, and ethnicity 15% were Hispanic. Next slide, please. So the evolution of our telehealth services. There was limited availability before 2020 in the whole Harris Health system. And once the COVID pandemic started in 2020, the whole system expanded because of the COVID-19 pandemic. And we started increasing telehealth services to reduce the number of patients coming into the clinic, to increase social distancing, etc. First, we started off with telephone-based visits, and then we expanded for face-to-face visits. Next slide, please. So we've used multiple streams of HRSA funding to create our telehealth program. And that included the fiscal year 2020 coronavirus supplement funding for health centers, health center coronavirus aid, relief, and economic security, or known as the CARES Act funding. Fiscal year 2020 expanding capacity for coronavirus testing, and the American Rescue Plan Act 2021. And in the next couple of slides, I'll detail what specific items we paid for out of each of these grants. Next slide, please. First grant that we received was the Corona Supplemental funding. And with that, we purchased personal computers with monitors, speakers, and webcams. We purchased iPads, and we paid for monthly line charges for internet services to connect with Harris Health server to access the electronic medical records and to transmit video. Next slide, please. With the CARES Act funding, we purchased or paid for telephone and cable company services for wiring for internet use for telemedicine, and we created telehealth rooms in a couple of the clinics. Next slide, please. With the ECT funding, we purchased laptops and Wi-Fi hotspot jetpacks. Next slide, please. With the American Rescue Plan Act funding, we purchased telehealth cards, mobile telemedicine examination kit, and that is a kit that is carried like a backpack with features that include a tablet with LTE and Wi-Fi connectability within a durable hard case. It includes a digital stethoscope, high definition ear, nose, throat, and skin camera, USB ports for any additional peripherals, as well as detachable Bluetooth keyboard with trackpad. And these features allow the medical provider conducting outreach or back at the clinic the information needed to examine and diagnose patients anywhere. We'll be using the mobile tech kits in outreach and encampment areas. And I will share the link to the mobile tech info on the chat feature later. We also purchased laptops and Wi-Fi hotspot jetpacks. Next slide, please. So in summary, we started using off phones in outreach settings, and the outreach staff connected the individual homeless patients to the providers, and then now we're going to start using iPads. And at some of the clinics, we created telehealth offices. Next slide. We currently finished conducting needs assessment for telehealth services, and we found that for us to continue using iPad out in the field, we need to improve the iPad connectivity, as there are some issues in the connectivity with the electronic health record. And then based on the space that we have within each of the individual shelters, we need to determine for the telehealth rooms if there's enough space just for computers, or we can add telehealth televisions that will allow for the interaction between the patient and the provider. Increasing the telehealth services will also allow us to increase access to specialty care, including second opinions and psychiatry services within Harris Health System. And we will be hiring a part-time telehealth director so we can bolster a full range of telehealth services and will increase access to care. We will continue offering telehealth services in shelters, even when clinics are co-located, to provide additional options for patients to access care safely. Thank you. I will pass it back to Norm, and he'll let me know when it'll be time for Q&A.
Thank you so much, Nelson. I want to ask a couple follow-up questions. A great presentation, and I like how you walked through a lot of the sort of details about how you implemented this. But can we sort of take a step back, and can you talk about where did you find that the telehealth activities were most helpful? Like, what were the use cases that you really felt like the telehealth infrastructure you developed was really helpful?
I think it was really helpful, particularly in outreach and encampment areas, since some of those individuals may have less trust and may be unwilling to come into clinics. Plus, not all the clinics are open access. Like I said before, since some of the clinics do not allow unsheltered or people not residing at that facility to come into the clinic for security reasons.
And so can you talk about how exactly did that work in encampments? So were you giving iPads to outreach workers who would go into the encampments, or were you, how exactly was that connection working?
Initially, they were using their outreach telephones and allowing the patient to use it to connect to the provider back at the clinics. And then we expanded to the iPad, which allows not only verbal communication, but also visual communication.
And you know, if you had to sort of like, I don't know how to ask this, but like, did you find the telehealth visits were as helpful as in-person visits? Was it, you know, like halfway as helpful? Or can you talk about, certainly if somebody wasn't going to do an in-person visit and telehealth was the only option, that's great. But can you talk about like how much, you know, how much do you lose when you do a telehealth visit? Or maybe you gain things in a telehealth visit versus in-person visits?
I think we gained, and as far as the providers, they haven't shared any negative feedback regarding losing anything during the telehealth interaction.
And did you, I know people think about Houston as sort of a city, and but Harris County, I know, is actually geographically very large.
Yes.
Were you using this for people who are sort of residing in, you know, like to cut down on some of the transportation issues and to be able to do better outreach to people who are located further away?
Both, and I think as we move forward, our health system is a large system, but it still is not capable of meeting all the services for the large population of uninsured in Harris County. But adding this service will allow the homeless individuals to access not just our services, but also many of the specialty services that the system provides. So I think it'll help link them by reducing transportation as a barrier.
Great. Thank you so much. I definitely appreciate you running through that with us. I'd encourage, if any of you have any questions or are trying telework or doing telehealth activities, sorry, not telework, but telehealth, can you, we'd love if you could share your experiences in the chat window, or if you have any questions, please feel free to go ahead and type those in the chat window. We'd love to hear about them. So we're going to move on to, thank you so much, Nelson. We're going to move on to our next presentation. Very happy to introduce Brett Esters. Brett is going to talk about a new document we have that we developed in partnership with FEMA. And Brett, I'm going to turn things over to you.
Great, thanks, Norm. Norm he presented it correctly. We published just this week a document that we co-authored with FEMA that provides information to communities on strategies and funding sources that are available to rehouse in permanent housing individuals and families experiencing homelessness that are sheltering in non-congregate shelter that has been set up to prevent the spread of COVID-19. So as a little bit of background, non-congregate shelter has been a life-saving resource during the pandemic. There's no doubt about that. It's prevented high-risk individuals from contracting COVID, and it's prevented the spread of COVID to others in the community. But we know that housing is the best place for people to be to prevent the spread of COVID. So the resource that we developed in partnership with FEMA is really designed to help communities move people who are experiencing homelessness that are sheltering in those non-congregate shelters to housing. It focuses on strategies to do that and the funding resources that are available to support that work as well. It's important that communities take a look at this document, and if you haven't already, start planning for that transition from non-congregate shelter to housing now. People are exiting from non-congregate shelter all the time. We know that a lot of communities are demobilizing some of their non-congregate shelter, and so it's important that you put together this transition plan now. But communities are in completely different places regarding the spread of COVID, so you'll want to work with your public health officials in developing and implementing your transition plans as you exit people from non-congregate shelter to housing, to make sure we're doing it in a safe way from a public health perspective. So if you take a look at the document, you'll notice that it's set up as a series of FAQs. These FAQs, after a pretty substantial background section, but these FAQs will walk you through what is non-congregate shelter, what is a transition plan, when should you start implementing the transition plan, what strategies should you include in that transition plan, what resources can be used to support people in housing people in permanent housing, along with the necessary wraparound services to help people maintain that housing. And the partners that should be involved in that transition plan and implementation of the plan. And it's definitely a lot of partners that need to be involved to ensure that housing is available, services available, and that we're keeping people safe from a public health perspective while we move them into housing. So for more information, take a look at the document, which Letitia has put in the chat. We also recorded a webinar with FEMA a couple weeks ago that covered much of the information that was in the document. And we also highlighted two communities, Indianapolis, Indiana, and the state of Connecticut. And they presented how they were housing people from their non-congregate shelters, including the resources and the strategies that they used, which was super helpful. That should be posted, if not today, then by Monday. So with that, I'll turn it back to you, Norm.
Thank you so much, Brett. And again, great resources in that document, and I definitely encourage people to check it out. And the webinar was great. We had some great presenters from FEMA, from some community presenters. As Brett mentioned, it was just a good session, so we'd encourage you to check out the webinar as well. So next, I'm happy to introduce Heidi Schultz and Marlisa Grogan. Heidi from Cloudburst Consulting and Marlisa from the SNAP's office. They are going to talk about reevaluating your ESG-CV approach, as you can see on the screen. So I'm going to turn things over to Marlisa to go first. Marlisa?
Hi, everyone. Great to be with you today. I wanted to highlight a new resource document that we have that's going to be posted very shortly. It is about reevaluating your ESG-CV approach. And as we're getting closer and closer to the 20% expenditure deadline 6 days from now, we are having more and more conversations with recipients who haven't quite hit the mark yet. And we're learning a lot more about some obstacles that recipients across the country are facing. Some of you have created strategies for spending down your ESG-CV funds, and that has worked really well for you from the beginning of your pandemic response, and you're seeing that the needs in your community are largely the same or are still being addressed using your initial approach. For others of you, your initial approach may have hit some obstacles, and we're hearing different strategies for addressing those types of situations. So this resource document that we are excited to share with you in short order, and we're going to go over in more detail today, is about ways that you can take a look at your current approach to ESG-CV, and in light of the changing landscape, think through whether the budgeting that you've done for your ESG-CV funds needs to be tweaked, and ways that you can consider adjusting your response in light of those changing community needs. And we've highlighted some examples for you to consider. One of them is, it's a high transmission rate across the country that Ashley reviewed with us today. Consider whether your jurisdiction is experiencing shelter outbreaks and higher COVID case counts. And in that case, you may want to strongly consider reprogramming ESG-CV funds to emergency shelter and street outreach to make sure that you have adequate infection control measures in place, that you're continuing protocols, and you're using new eligible activities that are authorized under the updated ESG-CV notice, like vaccine incentives. And then you could also think about expanding non-congregate shelter or putting more money in rapid rehousing. A number of states still have eviction moratoria in place, and so a number of you are finding that you're still having a hard time spending down your homelessness prevention money. So shelter, street outreach, rapid rehousing, these are all really important uses of ESG, and this is the time. This is the time to take a really close look at the new eligible activities under the ESG-CV notice. Consider your emergency shelter needs, your street outreach needs, and whether you could shift the funds around to bolster those as well as rapid rehousing. So with that, I'm going to turn it over to Heidi. She's going to go through the nuts and bolts of the process from the HUD perspective, and it's really important to know where you have flexibility and how you can make quick changes to your program. Heidi?
Perfect. Thank you so much, Marlisa. And just to do that bit, can everyone hear me? Yes. Okay, perfect. Next slide, please. And actually, this is just summarizing what Marlisa just eloquently put out there about, reviewing what's going on in your community. And so next slide, please. And part of that review, look at your internal fiscal records, look at IDIS and see, do you have funding that hasn't yet been committed to an activity? Is funding, based on what you're expending, looks like it may or may not have been allocated for an activity, and make those changes. Make sure you review your written agreements that you have with your providers to see if it is possible and when it is possible to reallocate funds. And fortunately, a good thing about next Thursday being September 30th, the end of the quarter, and also the first progressive expenditure deadline, the 20% expenditure deadline, all of our ESG recipients are going to be looking at their expenditures and submitting those in stage during the month of October. So it's a great time to look at what your providers are reporting as being expended and making those determinations of, do we need to change our approach? And if the answer is yes, then we're going to talk about what that looks like. Next slide, please. So first and foremost, review your organization's citizen participation plan per 24 CFR Part 91.105 and 91.115 for the specific criteria that your organization identified that determines whether a substantial amendment is needed. For many communities at the beginning of the pandemic, they revised their citizen participation plan and made those more flexible. And that way they were allowed to, again, increase that level of flexibility for the community to prevent, prepare for, and respond to coronavirus without needing a substantial amendment. So first step is review that citizen participation plan. In addition, keep in mind that normally when you think of a substantial amendment, there's this public comment period. However, the funds that are utilized to, again, prevent, prepare for, and respond to coronavirus are not subject to that citizen participation requirement in Part 91.115. That means that, again, that traditional 30-day public comment period for a substantial amendment has been waived. However, with that being said, in lieu of that public comment period, the ESG recipients, you are required by the CARES Act to publish on your government website or some other similar form of electronic media how those ESG CARES funds will be used in your local jurisdiction. And the document that will be published very soon on the HUD Exchange goes into some best practices that are really, really key for this area. Although things may not be required, these are some of our best practices. So, post a one-page summary that outlines what's being changed in your plan. Make it very easy to read, and that way, you're increasing that level of participation, engagement, and transparency with your local jurisdiction. Share that plan with your impacted subrecipients and providers, that way to, again, facilitate engagement. And then also consult with your local continuum of care regarding the changes. Now, per CPD Notice 2108, ESG-CV and ESG annual funds that are used to, again, prevent, prepare for, and respond to coronavirus are not subject to that COC consultation requirement. But again, as a best practice, even though that's been waived, it's still a really good thing to do to increase that level of engagement, make sure that there's a system-wide approach for ending homelessness in your community. Next slide, please. Now, the document does provide these 4 scenarios as to whether or not a substantial amendment would or would not be triggered. And so I don't want to be that person that reads every word on the PowerPoint, but I did want to include the table because, again, it's directly in the document that will be published. And some good things to pull out from here is if in your original annual action plan, you included at the ESG recipient level a goal outcome indicator for homelessness prevention and rapid rehousing, if you're going to move funding back and forth but from one activity to another, a substantial amendment is most likely not going to be triggered because both of those goal outcome indicators were already included in the annual action plan. So if the annual action plan on that same thought process did not include those goal outcome indicators, a substantial amendment would be necessary at that point in time if you were moving funding from one activity to another. And now if you, again, carrying with that same thread, if you're moving funding from one existing activity to another that, again, prevents, prepare for, and respond to coronavirus, a substantial amendment is most likely not going to be triggered. However, if you are going to reallocate funds to a new activity, that would most likely trigger a substantial amendment. But again, refer to your citizen participation plan for those specific criteria for what constitutes a substantial amendment. Next slide, please. So creating a substantial amendment, again, that public comment period has been waived for the ESG CARES funds, but creating a substantial amendment is still a system functionality that would be done in the Integrated Disbursement and Information System, otherwise known as IDIS, and it's specifically done in the Econ Planning Suite. Oops, I'm gonna take a quick sip of water. And I didn't want to go through all of the specific screens that are needed in the Econ Planning Suite to make that substantial amendment and submit it. So instead, the document that will be posted on the HUD Exchange includes these 3 resources. They are full of screenshots, so lots of screenshots if you're a big fan of those, and arrows and all those super fun things, and go through those. And it's very simple as to when submitting a substantial amendment in IDIS, there's one ESG project in the action plan, so you would only need to change the description in the activity detail in that one specific box. If your annual action plan is currently labeled as review completed, then you would just click the amend link to reopen that action plan, and then again, follow those screenshots. It's a fairly straightforward process. Next slide, please. So after that substantial amendment process or not substantial amendment process, whether or not one is needed, in IDIS, most likely you might be moving some funding around from one subrecipient to another within the same activity level. So maybe within rapid rehousing, one provider is doing really, really well, so you're going to increase their funding there, or you're going to move funding from, as Marlisa was saying earlier, from homelessness prevention to rapid rehousing. What you would do in IDIS, the best thing to do first on the activity funding screens, decrease first. Decrease whatever you're decreasing, so decrease all the subrecipients that you're decreasing, decrease at the activity level, and it's by subrecipient, and then hit save, and then go ahead and increase that activity funding. Sometimes it gets difficult and everyone's very ambitious to go ahead and increase funding, but there are funding caps in IDIS. You can't fund over your grant amount, so it's just one way to make sure that there's funding available. IDIS does have some math involved with it, so it's always a best practice to decrease activity funding first, then go ahead and increase everyone. So just wanted to put that out there. Next slide, please. And so again, the substantial amendment is done in IDIS. Oops, sorry, I flipped onto the wrong slide on my screen. So some quick reminders. I know it seems difficult to maybe comprehend, We are in September of 2021. However, if you originally as an organization amended your fiscal 2019 annual action plan to include your ESG CARES funding, you're going to go back to that annual action plan and amend it. Likewise, if you included your CARES funding in your fiscal 2020 action plan, that's the annual action plan that you will go back and make that substantial amendment. So it's not your 2021 annual action plan, it's your 2019 or your 2020. And then finally, once you have made those updates, please update your IDIS activity description to articulate how those funds are being used to, again, prevent, prepare for, and respond to coronavirus. And there is a wonderful resource here linked that is available on the HUD Exchange that gives you lots of really great descriptions on what it means to prevent, prepare for, and respond to coronavirus and what that looks like for street outreach, what it looks like for shelter. And it goes through all of the activity categories. So it's a wonderful, wonderful resource. And as always, for anyone who's ever dived into IDIS, your ESG CARES funds will stay within the 2020 ESG project. Even if it was in your fiscal 19 action plan, and definitely it was in your fiscal 2020, it's in 2020. It's just going to stay in 2020. That's where the project is. It might be associated with a fiscal 19 action plan. That's okay, but it's going to stay in that 2020 project. Next slide, please. And as always, if you have questions about whether or not a substantial amendment is needed, reach out to your field office. They are going to be your best resource for that type of question. Additionally, you can certainly ask questions on the HUD Ask a Question. If you have something related to, a substantial amendment, there's a drop-down menu that asks my question is related to. Pick the Econ Planning Suite. That's where annual action plan, substantial amendment, CAPER, those things go to the Econ Planning Suite. If you have a question related to, activity funding or adding subrecipients, removing a subrecipient, pick the IDIS question pool, and I'll probably be the one answering it. So again, there's that link for where you would submit those questions on the HUD Exchange. If there are any questions, happy to take them now. If not, back to you, Norm.
Thank you so much, Heidi. We did have a question about the timing, because normally you can't amend an action plan after a year. So can you talk about, so ESG-CV is a little different here. So when can people amend? So you talked about how it might be in their 2019 or 2020 action plan. So what are the how long can they do substantial amendments for?
So the Con-Plan Desk Guide is probably a bit out of date for that. Again, this was a global pandemic. It's not going to fit within the same standard process of when those deadlines are for when you can and cannot submit a substantial amendment. So you have these funds. They are identified in, again, either a fiscal 19 or a fiscal 20 action plan. You have that expenditure deadline of September 30th of 2022. So it's very possible that you could be making a substantial amendment well into 2022 to update your program design to meet that expenditure deadline. So I wouldn't follow the Con-Plan Desk Guide in that regard, because those timelines don't exactly hold true for CARES funding.
Great, thank you so much. I think there are probably a couple other questions in the chat window, but we'll move on to our next topic and give you a chance to dive into those. So I'm very happy to introduce Sharon Singer. She's going to walk us through how we're doing on ESG-CV spending, and also she's going to talk about our poll question. So you got a final chance to submit your responses to that poll question, and Micah just helpfully put that in the chat window for you. So with that, I'm going to turn things over to you, Sharon.
Hi, everyone. Happy Friday, and the countdown to the end of the fiscal year. Exciting times. I know we've been, everybody's been mentioning the September 30th is 6 days away, so next Thursday. And as you can see, the good news is we've gotten all grant agreements signed, which we had a few stragglers, but both ESG-CV 1 and 2 are in there. Just a few funds that need to be loaded into IDIS. So we have 99.5% of the funds are up and running. So that is excellent news. The funds are obligated. And then we also have a large number of funds now committed at 85.2%. So folks are making those plans for how to spend the funds. And we are nationally over the 20% mark, which is great. Almost 21% at about 822 million. Sorry, I don't want to mix up my millions and billions. So we have over 50% of our recipients are over 20% drawn, which is great news. And we know that many of you are working tirelessly to reach this threshold, and that many, hopefully when we meet with you next, a very large majority will have met that 20%. And I know there's been a lot of communication from our office, and I've been seeing the responses coming in from across the country as to how you're planning to meet that 20% goal. So please just communicate with our team, let them know how you're doing. If you need assistance, we are here. And your CARES Act staffer, hopefully by now you know them via email at least, and they are here to try and assist you. So you can go to the next slide. And just to show kind of we've ramped up, there was that jump in our draws in July. You can see kind of the trend line bumped up, and we've maintained that increased slope of spending. So that is good news. And again, this is just the draws because this is what we at HUD are able to see in IDIS. Obviously, your reports of expenditures in SAGE are important and are what is being measured for September 30th. So please make sure that you are reporting on your expenditures. And if there's any confusion, again, please reach out to our team. So good luck with these this final few days and getting things together. So I'm going to switch over to our poll question, and Micah is loading that. And of course, you made the answers as small as possible, so the glasses are going on. And the question this week is, how has the pandemic impacted the relationship between your local COC and healthcare for the homeless programs? Please check all that apply. So we got a low response rate. I know there's many more of you out there. We have we have 6 responses for both established partnerships for alternative care sites and no impact, little to no coordination of services continued throughout the pandemic. So that's not a positive that there's a large number there. So for those who don't have that coordination, that's something to work with, and our Healthcare for the Homeless partners are often on this call. Next up, we have 5 that say they strengthened mental health and substance abuse coordination of care, which is great news. 4 each say created pilot programs to address service gaps. Again, we'd love to hear more about that for those of you who have done that kind of thing. And 4 also, we jumped up to 5, increased convenience with more mobile telehealth services. So this is all really creative work that's obviously happening on the ground. Next up, we've got 3 of you say that you expedited medical care due to prioritization such as rapid response teams. 2 of you said that no impact, strong coordination existed prior to the pandemic. And then 1 person said created new data sharing protocols. So great to hear that there's some really good proactive work going on. Please feel free to share any best practices with us. We are always eager to hear what is going well. And it sounds like we got a couple more people jumping in. So establishing partnerships seems to have gone up. So that's great to hear. And I am going to pass this back to Norm.
Great. Thank you so much, Sharon. And thank you, everyone. I know people have been working really hard to enter those draws and get credit and get funding for those activities. So thank you so much for that. So I want to just make a couple sort of, well, actually want to go through some of these next slides. We have some additional resources we want to show you. But I also want to quickly talk about a couple things. One is I want to talk about House America. So many of you may have heard the announcement on Monday. HUD and many mayors, governors, and tribal leaders across the country did a joint announcement on House America, which is an all hands on deck to house people experiencing homelessness. And I just wanted to talk about that a little. We are going to put a link to House America information in the chat window here, so you can take a look at what that's about. But this is really a partnership between the federal government, including HUD, the U.S. Interagency Council on Homelessness, and other agencies. Partnership between federal agencies and state, local, and tribal governments with the goal, as it sounds, of housing as many people experiencing homelessness as possible, with a goal of trying to do as much as possible by December of 2022, so a little over a year away. And many of you, all of you possibly, are involved in this work, right? Involved in the work of housing people experiencing homelessness. So we wanted you to be aware of that resource. We wanted to give you a link to the site so you can kind of see what that's about. If your mayor or governor or tribal leader has already signed on, that's great. We're delighted to work with you on this. If they haven't, you are welcome to encourage them to sign on. If you want more information about it, you can definitely look at the site. You can also reach out to your field office or submit an AAQ or even ask questions in the chat window, and we'd love to talk to you more about House America. But I just want to emphasize the goal here is not to create something new or different than what you're already doing. We know that you are engaged in the work of housing people experiencing homelessness, and this is really a way to join our work with yours and to really partner on this and to really help support you in this work, both at an operational level if you need help with technical assistance and those kinds of things, but also in a messaging way and in a political leadership way to show that there is a lot of support for this, and we want to make sure that every resource is behind you in this work. So thank you for indulging me on that. I also wanted to mention that we have a webinar coming up on September 28th, so next week, on COC and tribal work on the COC NOFO. So this, as many of you know, the 2021 Continuum of Care NOFO is the first opportunity for tribal organizations to apply for a COC grant. And we want to provide you with more information about that and to talk about how to work together on that. So we do have a webinar coming up. We will post the link to the webinar in the chat window as well, so you can see when that is available. We did send out a listserv message, I want to say earlier today, it might have been yesterday. And so please, look, you can also look for that there, but we'll also post that link in the chat window. So we're going to turn to the Q&A portion of our session today. So I want to first ask about, we had a couple questions about expiring waivers earlier in the session. So Brett, I want to turn things over to you. I know that we do have some waivers that are expiring, and those will not be extended. And then we have some waivers that are continuing through at least December. Can you talk about the waivers that are expiring?
Yep, so there are 4 that are expiring at the end of September that we do not intend to renew for the COC and YHTP program, and then there's a couple others for the HOPWA program. So the ones that are expiring for COC and YHTP, the first one is you're now going to have to follow the normal orders of priority for documenting income. So throughout the pandemic, we have waived the requirement to follow, try to get third-party documentation of income. And if you can't get that, you can get a self-cert by the program participant and let you go straight to self-cert by the program participant. So now that's going to expire and you'll have to follow the orders of priority in the regulation for documenting income. And then 2 of them are related to housing quality standards. So throughout the pandemic, we have waived the initial physical inspection of the unit. That is expiring at the end of the month. So starting in October, we're going to expect you to inspect units that they meet housing quality standards before you can provide assistance on behalf of a program participant. And then you're also going to have to start to inspect all of those ones that are still occupied by program participants that weren't physically inspected. And you'll have until December to do that. And then the one related to re-inspection. So throughout the pandemic, we haven't required you to re-inspect units annually for that they meet HQS standards. So that also is coming back into play starting October 1st. So we will expect you to start re-inspecting units as well. And then the final one that is expiring is the waiver for monthly case management. So throughout the pandemic, again, we have waived that monthly housing stability case management requirement for rapid rehousing projects. That waiver or that requirement is coming back. So for rapid rehousing program participants, you'll be required to do monthly case management. But just as a reminder, that doesn't necessarily have to be in person. You can do that over the phone. You can do that through some of actually the telehealth stuff that was talked about earlier. That would be a good way to do case management as well. So starting October 1, the monthly case management for rapid rehousing comes back as well. And then the rest that were in that mega waiver published back in June, I think, those expire on December 31st, and we have not made a determination at this point yet whether they will be renewed.
Great, thank you so much, Brett. I also want to point everyone to another webinar that will be coming up, I guess, next Thursday. So if we could advance the slide to that ESG webinar here. Thank you. We have a webinar, as you can see on the slide, Thursday, September 30th, 2 to 3 p.m. Eastern Time. And it's about the ESG-CV quarterly reporting process, how to report on activities, et cetera. So if you're interested in that, please definitely sign up for that. There's a link in the chat window that Letitia helpfully put there just now. So, so just wanted you to be aware of that. So I also want to pull out a question from the chat window. I think I'm going to ask Marlisa about this one. So Marlisa, there was a question about the 14-day limit on when tenants must vacate their unit to qualify for ESG assistance, and that it's extended to 30 days. And we had a couple people who had questions about that. Can you talk about what is that requirement and sort of what is its status?
That is a good question, Norm, because I actually read that question to be in reference to HUD general guidance. So maybe the questioner could specify if they meant an ESG requirement or just general eviction guidance that HUD put out. Or maybe you have a sense, Norm, that this definitely is. I don't believe that this is an ESG requirement.
Okay. Honestly, I had no idea what I was hoping you would know, but I'll tell you what, we will take a look at that. We may reach out to you all to follow up on that question, and we will try to get you a response about that and bring it up on the next office hours as well. So thank you for the question. Occasionally we get stumped about things, and you manage that. Thank you. So with that, I think we're back to the end of our questions here. I want to thank everyone for joining. I want to do a special shout out this week for like the people who organized this webinar, Letitia and Janet especially. There is a ton of work, as you can imagine, that goes into organizing this webinar, and the whole process comes off incredibly efficiently and flawlessly. So I wanted to thank you all for the incredible skill with which you do this. I want to definitely thank our presenters. I want to thank Nelson for talking about telehealth with us, a really great informative presentation, and want to thank Heidi and Marlisa and Brett for talking us through those resources, and Ashley for our regular CDC update, which is always good to hear. Well, it's better to hear when there's good news, but appreciate that. And Sharon, thank you for giving us our ESG-CV update. Again, want to thank all of you for your incredible dedication to this work. We are truly in unprecedented times here, and we are all, trying as hard as we can to get through this. And I just am constantly awed by the incredible work you're doing. So thank you so much, and know that we are here to support you. And I want to wish everyone a great rest of the day, great weekend, and that concludes our webinar.